Good morning. I'm Frances Howie, Director of Public Health at Worcestershire, and I'm delighted to kick things off today and to welcome you all to what I know is going to be a really inspiring and motivational day. I'm the Director Lead for the West Midlands Association of Directors of Public Health for suicide prevention, so I'm extremely sorry not to be with you today. However, I do now work in local government and Cabinet must come first, and that's where I am this morning. So suicide prevention. It's a really important moment now in the development of our national approach to this. We've now got our 2012 suicide prevention strategy. We've got a couple of reports that updated progress against it, but really positively, we've now got an indication that there will be a refreshed strategy this month, January 2017. And just before Christmas, excellent news, the interim report of the Health Select Committee on Suicide Prevention, chaired by Dr. Sarah Wollaston, was produced. And the aim is for that report to inform the refreshed strategy. I'm sure you've all had the opportunity to look at it, but if not, just the first sentence is strong enough. The scale of the avoidable loss of life from suicide is unacceptable. And it states really clearly, suicide is preventable, and much more can and should be done to support those at risk. So a really important moment, a really important recognition of suicide prevention. And Public Health England at the national level has given incredibly valuable expert guidance by producing a series of toolkits over the last year or so. So we've got some really tailored information and guidance about how to develop a local suicide prevention plan, about how to prevent suicide amongst LGBT communities, how to identify and respond to potential suicide clusters, how to prevent suicides in public places. And we've got some really great data as well from Public Health England, including the suicide prevention profiles, and you'll be hearing much more about those later on in the day. Suicide is, of course, one of our most complex and enduring public health problems. I believe that it's unique, both in the devastating impact not just on the individual, but then also in terms of the families and friends of those who have taken their own lives. And the families and friends live on. I personally won't forget the words of a local resident on my patch in Worcestershire, a bereaved wife who came to a meeting of full council speaking with remarkable dignity and bravery, making it absolutely clear that more can and should be done to prevent suicides in the future. And we have all of us, I'm sure, have words like that in our minds. The guidance and the data is fantastically valuable at structuring our approach, in terms of how to think, how do we do more, what does it look like? And I'm sure that many of us now are in the process of rethinking our local plans and our local approaches in the light of the guidance that's coming out to us. So today is really particularly very, very well timed. But it will only be a success if we are able to shape, as a consequence, a refreshed and remodelled set of actions to prevent suicide in the West Midlands. We will then be able to judge our success on whether or not those actions do prevent suicide. So in terms of how we measure that success, in terms of measuring suicide, I'd just like to briefly outline a few facts and figures about suicide in the region. But remember, suicide data does come with a warning. Coronial verdicts are not moderated nationally, and narrative verdicts are increasingly common. So the sort of data that we talk about, the validated national sets, are probably lower than the true number of suicides. So at its starkest and simplest, the data tells us a West Midlands age standardised suicide rate per 100,000 population of 10.3, a little above the national average of 10.1 per 100,000 population. It also tells us there's some variation across our region, from 9.2 in Solihull to 11.8 in Warwickshire. And it tells us in terms of numbers, putting the people on that data, that across the West Midlands, between 2013 and 2015, there were 1,500 suicides, 1,525 people who took their own lives. In my patch in Worcestershire, on average, one person a week takes their own life. Every year, and the figure has been stable for years. So that's one person a week dying from a preventable cause of death, and we haven't changed it over a number of years. And of course, those figures, we can express those as numbers of years of life lost due to suicide. So the age standardised adult rate per 10,000 population was 33 years in the West Midlands, compared with 31, 32 nationally. And again, variation across our patch, 24 years in Dudley, 48 in Stoke. But the losses from suicide aren't just in terms of the years of life that have been lost to the person who's died. There's also the health impact on those who've been bereaved and left behind, the families and friends. And there's also the mental ill health toll that has been taken on the individual in the years that precede the suicide. And then we've got the social cost to societies and to communities. Estimates vary. The Select Committee reports that every single suicide costs society 1.67 million, total cost of 0.85 billion a year. So a massive cost to individuals, to communities and to society from this preventable cause of death. So how can we tackle and prevent this burden of disease and early death? Well, first and foremost, we've absolutely got to start to see suicide as preventable mortality, not an unpredictable random event. Just like any other cause of premature death, there are risk factors, and these can be screened for, they can be identified, and they can be mitigated against. And we can find direct means of intervention, and we can find primary, secondary and tertiary means of prevention, just as with any other premature death. So what does the data tell us about who's at greatest risk? Firstly, it's men. In the West Midlands, the age standardised rate for men is 16.6 and the rate for women is 4.7. So a big difference between the genders. Secondly, age. Those under 50 are at greatest risk. Death by suicide is now the leading cause of premature mortality in men under 50. Other people who are at particular risk, those in the criminal justice system, people living with long-term health conditions, people living in disadvantaged circumstances, people who self-harm, people in certain occupational groups such as farmers, former military personnel, doctors, people who are vulnerable because they themselves have been bereaved by suicide. People who are bereaved by suicide have 3 times higher risk of taking their own lives. People in marginalised groups, people who are unemployed, people who are in LGBT communities. So it's not a secret. We know about the risks, we know who those people are, and we need to find new ways to reach them with the right interventions. And what does a good local response look like? There's brilliant guidance out there, and you'll all be familiar with at least some of it, and I'm sure from today we'll be going back energised to go and have another look at it. But just to summarise some of the key points about the next steps in terms of moving forward for a really solid, strong local response. Firstly, we need a strong local partnership. The people that need to be around the table are not just the mental health services, it's all the health services, it's social care, it's other statutory partners like the police, like the district councils, VCS organisations, it's bereaved families and friends. They have a strong lesson to tell us. The experiences that they have are the ones that we have to learn from. But local health providers are key, both, again, primary, secondary, tertiary levels. About a third of those who took their own life in the last year are known to the local mental health services, and about a third have been to see the GP in the month before they die. So we need to have then a second point, a very consistent approach to training for frontline staff, right across the spectrum, from health through those other statutory partners and into business and employers. A very clear, consistent approach to training, how to identify the risks and then what to do about them once identified. We need a granular understanding of our local suicide data, and some of that from real-time data, working really closely with the coroners and really closely with first responders. So some real-time stuff so that we can consider possible clusters, identifying trends and building our local evidence so that we can tailor our solutions and interventions locally in the most appropriate way. And then we must have agreement on media management, on how to deal sensitively with reporting so that we can really get on top of the fear of copycat events and contagion deaths. So really consistent and clear across all those partners how we deal with the media. And in terms of thinking about our interventions, we've got to demonstrate that asset-based approach, not a deficit model, an asset-based approach, so that we understand what universal and targeted interventions can build on what there already is. We need to demonstrate really strong campaign work that destigmatises mental health. There is a conspiracy of silence around mental ill health, and people have done a lot in years gone by, but we need to do more all the time to take the stigma away from this. We need to include support for those who've been affected by suicide of friends and family, and we have to listen to their voices. And then a final point from the guidance, we have to implement the reforms that were in the 5-year forward view for mental health. So things do need to change. There's a great deal to do. But we've got the greatest of motivations now. We want to be the people who speak out and who make suicide prevention a reality. And let's not forget in these opening remarks that in even having a suicide prevention masterclass at all, we have to acknowledge that we are standing on the shoulders of all those who've campaigned for many years to destigmatise mental illness and destigmatise suicide, to get rid of the feelings of shame that so many people describe, to bring it out into the open in order to tackle it. Many of the people who I'm talking about have been directly affected by this most devastating of losses, and many of us in the room today will have been too. Others are from voluntary organisations such as the Samaritans, who've done such a great deal to change the way that society supports people with mental illness and those who are bereaved. So I'm sure that we do come together today with those people at the front of our minds, front and centre, and with the words of Sarah Wollaston from the Select Committee right in our ears: suicide is preventable and much more can and should be done. So I'm not going to take up any more time. This is our real opportunity to make a difference, to articulate a vision to prevent suicide right here in the West Midlands right now.